All right.
Well, let me introduce you, Doctor. Thank you very much for being here.
Sure.
Sorry for the technical problems. We are right now here in the chat in this meeting about 50 psychiatrists from Mexico. Most of them are CL psychiatrists, and it's an honor to present you, Doctor, because any psychiatrist that wants to be a CL psychiatrist should read your books, should read your contributions, and it's an honor to have you here for the first time in Mexico via Zoom in this pandemic. And it's an honor to Tecnológico de Monterrey and the entire country of psychiatrists to have you here in this lecture. So thank you very much again, Dr. Levenson, and please start with your talk, Psychopharmacology in the Medically Ill. Welcome, Doctor.
Thank you. Let me know, though, should I stop at, exactly at 11 or at 10 your time? You're muted.
You have the entire hour to make your talk.
All right, thank you. I'm honored to be invited. Allow me to say it's a particularly auspicious week in a time of a lot of bad news in the world and in this country. Please allow me to celebrate that the US Supreme Court this past week struck a blow against President Trump's war on immigrants, which many of us are very happy about. Any lecture on psychopharmacology in particular, it's important to disclose any conflicts of interest. I have no financial relationship with any pharmaceutical company, but I do have a conflict of interest of sorts in that my books do address psychopharmacology and the medically ill, and I do receive royalties from them. It's also important, at least in the United States, that whenever talking about drugs, that if one is going to talk about any indications or routes of administration that are not approved by the US Food and Drug Administration, one must acknowledge that. And indeed, I will be talking about some uses and routes of administration that are not officially approved, but are really standard care. So rather than just a comprehensive lecture, particularly since we're limited to an hour, I could spend a whole half day on this topic easily. The way I've constructed the talk is to answer some specific questions that have come up in the interface between psychiatry and medicine, and tried to share whatever evidence or examples of evidence where there's a lot of evidence back up what I'm going to say. And I sent my slides ahead, and Carlos will share them with any of you. So please don't bother with trying to take notes or write down references as we go through this. So these are the questions I'm going to try and address. How much bleeding risk is there with SSRIs? A number of gastrointestinal questions about our medications. Within the realm of neurology, how to treat psychosis and Parkinson's disease. And busca tu distinguida dama, coge su panocha. And to what extent to worry about seizure risk. Within cardiology, I'll mostly talk about how much to worry about QT prolongation. Pulmonary, the safety of our sedating drugs in patients with severe COPD or severe sleep apnea. Some renal questions regarding lithium. To what extent our drugs pose perioperative risks and whether or not they should be stopped before elective surgery. Hyperprolactinemia and the risk of osteoporosis. Which medical drugs really do pose suicide risk, and then alternate routes of drug administration in patients who can't take drugs orally. So SSRIs and bleeding risk really raises four different concerns: GI bleeding, perioperative bleeding, postpartum bleeding, and stroke, hemorrhagic stroke. There's been quite a lot of studies of SSRIs and GI bleeding, although no randomized controlled trials. These are all either retrospective or cohort studies. And the studies generally fall into three categories: those that show no risk at all, those that show a small increased risk, maybe a 30% relative increased risk, and those that show a somewhat more significant relative risk, perhaps a doubling of risk. The absolute risk, however, remains very small. Fortunately, no study has shown an increase in mortality in patients from SSRI-associated GI bleeds. The risk does go up considerably if the patient is taking multiple antiplatelet drugs. So, for example, a patient who develops depression after myocardial infarction and might be on aspirin plus clopidogrel or another antiplatelet agent plus an SSRI, the risk there may be something like 15 to 25 times the background risk. And the presence of H. pylori increases the risk as well. Meta-analyses have generally concluded, looking at all of the studies to date, that the risk is probably by 36%. Oops, where did my slides go? Oh no, the host disabled screen sharing. You just
yeah, it will be able again, doctor. We will try to prevent these pirates of the internet. So it's only you that you're gonna share the screen.
Or if you can put up the slides.
Argenis, you can help me, please.
Yes, doctor, you can share your screen now.
Okay, thank you. Yep, there we go. Great. Okay. Interestingly, the risk is not increased if the patient is taking acid suppressants. The absolute risk is very, very small. The number needed to harm in a low-risk patient is over 3,000. And even in high-risk patients, you'd have to give an SSRI to almost 1,000, about 900 patients. So let's see, next slide. Oops. No, it's not letting me advance. Oh, there we go. So bottom line, there seems to be a small increase in relative risk. The absolute risk is very small. It's rarely clinically significant. It will go up if they're taking an NSAID and an antiplatelet drug. I would be careful in a patient with thrombocytopenia or platelet dysfunction like von Willebrand's disease. But there's no need to refrain from or to discontinue an SSRI or an SNRI in a low-risk patient. Do SSRIs increase perioperative bleeding? Don't focus on the details. This is just a sampling of studies. None of them are randomized controlled trials. They range from very surgeries where there would be very little risk of blood loss, like a facelift or invasive dentistry, to much more risky surgery, like major abdominal surgery. But the conclusion across all of these is that serious bleeding has been very rare, and there are many potential confounds in these retrospective studies. A systematic review concluded that there was a small increased relative risk. I think the bottom line is the absolute risk is very small. It's unlikely to be clinically significant, except in a high-risk patient. So let's say a patient with cirrhosis who had coagulopathy and very few platelets and needed an operation despite that. I would stop an SSRI before that operation, because that's very high risk. There's no data to guide that, but there I would think that small relative risk would become much more significant. do SSRIs cause hemorrhagic stroke? Do they cause CNS bleeding? Here too, the evidence is mixed. In general, elderly patients who are on SSRIs have 2.5 times the increased risk of stroke. But you must not take that at face value, because a meta-analysis found that there was the same degree of increased risk with ischemic and hemorrhagic stroke. So if anything, we would think if SSRIs increase the tendency to bleed, that they would reduce the risk of ischemic stroke. And the fact that SSRIs are associated with a risk for both kinds of stroke points to a confounding variable. And in fact, anxiety and depression are both independent risk factors for hypertension, and they're independent risk factors for stroke. And so being on an SSRI, I think because it's a marker for stroke risk, it's a marker because depression and anxiety are increased risk. That said, if someone has had an ischemic stroke, I would not start an SSRI in the first couple of weeks after that, when they may be still at risk of bleeding. So they're not contraindicated in thrombotic stroke. Even those patients receiving thrombolysis for a thrombotic stroke, you don't have to stop their SSRI, but I would not start it soon after hemorrhagic stroke. Do they cause or increase postpartum bleeding? Much less studied, unfortunately. Mixed results. A systematic review also reached the conclusion that they couldn't be conclusive. I think just like the other bleeding risks, I think caution's warranted in those at high bleeding risk, but not in others. Don't stop an SSRI just before, at the end of a woman's pregnancy, because that's going to increase the risk for a postpartum depression. In any of these patients, what about if the patient is on some form of anticoagulant therapy? Less and less patients are taking warfarin because we now have some safer substitutes. The basic, well, there's some mixed case reports and so on. The U.S. Food and Drug Administration does not consider a warfarin plus an SSRI to be an adverse interaction. I think if you start an SSRI on somebody who's on warfarin, it's a good idea for their INR, their pro time to be rechecked. But I think one would say that after starting any new drug in somebody on warfarin, just to be sure that there wasn't a drug interaction. There's no increased risk with enoxaparin. You may know it as brand name Lovenox. There have been no reports of SSRIs causing bleeding in any of the newer, once a day, single, same dose for everybody drugs like rivaroxaban or apixaban or dabigatran. So overall summaries of SSRIs and bleeding, there probably is a statistically increased risk. That absolute risk is quite small in most patients. It's rarely clinically significant. Don't stop an SSRI just before surgery or delivery in most patients, but who should you worry about? I would not start an SSRI in a patient who's in our bone marrow transplant unit who has a platelet count of 20,000. They're at risk for spontaneous cerebral hemorrhage already. A patient with von Willebrand's disease who's had a lot of bleeding episodes. A patient with cirrhosis who has severe coagulopathy. We have non-serotonergic antidepressants to use for such patients. And as I've mentioned, not right after an acute intracerebral hemorrhage, and not as first choice in patients on multiple antiplatelet drugs. All right, let's move on to the gastrointestinal system. In patients with malabsorption syndromes, you're going to have to use an increased dose of the drug. And in general, favor liquid when you can give them liquid. And I'm going to use gastric bypass surgery patients as a particular example. But the things that I have to say about them would also apply, for example, to patients with Crohn's disease who've had a lot of their small bowel removed, patients who have chronic pancreatitis and have severe malabsorption, and so on. In patients with delayed gastric emptying, you want to avoid anticholinergic drugs because they're going to slow down gastric emptying further. When most of our drugs are weak bases, and if they sit in the stomach a long time being exposed to stomach acid, absorption is reduced. And so one may need higher doses there. And quite obviously, avoid anticholinergic drugs in patients with severe constipation. A topic within the GI world is irritable bowel syndrome. Fortunately, more gastroenterologists have learned about the value of antidepressants in irritable bowel, but many of them still do not. And while depression and anxiety are very common in irritable bowel syndrome, multiple meta-analyses, these are all meta-analyses on this slide, not individual studies, they've all concluded that antidepressants, tricyclics and or SSRIs, are beneficial for IBS symptoms, even if the patient has no depression or anxiety at all. I'm treating a number of irritable bowel patients who got referred to me after nothing, they received no benefit from the drugs their gastroenterologist gave them, and somehow someone heard that I was treating irritable bowel effectively. There's been insufficient study of the subtypes. So there's 3 subtypes of irritable bowel: those who mostly have diarrhea, those who mostly have constipation, and those who have alternating diarrhea and constipation. And there's been insufficient study of, does it make much difference if the patient has anxiety or depression along with their irritable bowel? But just from a common sense perspective, it makes sense that if they have constipation predominant irritable bowel, give them an SSRI, because SSRIs loosen stool. They don't worsen constipation. But if they have diarrhea predominant or severe painful GI spasms, then tricyclics are more appropriate. And I usually use nortriptyline for that reason or for that purpose. How is drug absorption affected after gastric bypass surgery? As you know, the United States has an epidemic of obesity. And unfortunately, as the average standard of living increases in other countries around the world, obesity seems to come along with it. I know your country is fighting an increase in obesity and type 2 diabetes as well. There's been shockingly little research about how drug absorption may be affected, despite the fact that tens of thousands of patients have had these operations. And I'm not talking about restrictive surgeries like a gastric sleeve, but just bypass procedures like a Roux-en-Y, where you bypass most of the stomach and part of the small bowel. Generally, you skip the duodenum and the paroxysmal jejunum in a Roux-en-Y. And this is particularly relevant for antidepressants because they're the most commonly used medications of any type preoperatively among bariatric surgery patients. So if we tried to predict what the effect would be, theoretically, it's very hard, because by skipping exposure, reducing exposure to gastric acid, that would increase the absorption of most of our drugs because they're weak bases. But reducing intestinal exposure, where most drug absorption occurs, would reduce absorption. So those predictive forces are in opposite directions, and they're more complicated things that have to do with P-glycoprotein in the gut wall and changes in first-pass metabolism. We don't have time to go into those details. But basically, this tells us we need empiric measurement. And so what do we know? based on very small studies, some case reports, some collections of 4 patients or 6 patients. Most, but not all patients on SSRIs and SNRIs had a significant decrease in absorption. On the other hand, there have been multiple cases of lithium toxicity where the lithium dose was the same dose before surgery, and somehow they're absorbing it more efficiently after the bypass. There are literally no reports in the literature for other antidepressants, benzos, antipsychotics, mood stabilizers, stimulants, or cholinesterase inhibitors. So here's my bottom line recommendations. You should assume that many, maybe most, but not all, will have reduced absorption. So if it's a drug like a tricyclic where you can check a blood, or valproate where you can check a blood level, do that for those you can. Otherwise, you know, see how the patient is clinically responding, but have a low threshold for increasing the dose. But avoid slow release preparations, because slow release preparations are designed to loosen their coating while exposed to gastric acid. So by skipping that exposure in the stomach, many of those pills will go through undigested. So use immediate release forms, or crush, in some cases, crush the tablets, use liquid, and sometimes use higher doses. I had a patient for about, I was amazed he survived so long. He had Crohn's disease. He didn't have gastric bypass surgery, but he had had essentially all his small bowel removed. He survived for more than 20 years on intravenous hyperalimentation, received at home. And he developed a pretty severe depression. I ultimately had to give him, I was giving him liquid sertraline, and the dose was 400 milligrams a day to get a clinical response, because most of it was just going through unabsorbed. But he was able to get some. Do keep in mind that if the patient with gastric bypass surgery loses a whole lot of weight, like 100 pounds in that first year, most of our drugs are lipophilic, stored in fat, and you're going to have to reduce the dose. How should patients with Parkinson's disease who require antipsychotics be managed? For any of you who treat patients with Parkinson's, this is a real challenge. Psychotic symptoms occur in almost 2/3 of Parkinson's patients at some point. That study is the best study on the topic, and they looked at a large group of Parkinson's patients over an 8-year period. Maybe 25% of the time it will remit, but most of the time it gets worse. And the most common symptoms are visual hallucinations and paranoid delusions. It's usually in patients who have the dementia associated with Parkinson's. If they're not demented yet, it's a marker that they're probably going to develop dementia. If they already have REM behavior sleep disorder, that's where they're combative during sleep, kicking and hitting their bed partner, shouting, and so on. That is a strong predictor, very strong predictor that they're going to develop psychosis in Parkinson's with dementia. But psychosis is also a side effect of dopaminergic drugs. And so the first thing to do in a Parkinson's patient is to talk with the patient's neurologist and see whether the dopamine agonists can be reduced, but never, ever abruptly stop dopamine agonists in a Parkinson's patient, because that can precipitate the syndrome that's identical to neuroleptic malignant syndrome, with all the same mortality risks. When all we had were first-generation antipsychotics, most of you are too young probably to remember that time, this was really a dilemma, because drugs like haloperidol made the Parkinson's worse, so their L-DOPA drug was increased, which made the psychosis worse. So the Haldol was increased, which led to an L-DOPA increase, and it was just terrible. Well, what do we have now? We have some good options. Clozapine has been shown to be effective in several randomized controlled trials and at very low doses. Look at that dose range, 6 to 50 milligrams a day, way lower than schizophrenia, much lower side effect burden. And in actually the trial that was published in the New England Journal of Medicine, not only did not worsen the Parkinson's disease, the patients on clozapine had an improvement in their motor symptoms. That wasn't apparent in all of them. I'm sure, or at least I assume, pimavanserin is being heavily marketed to you in Mexico as it is in the United States. It has an FDA approval, and it's the only drug officially that has an FDA approval because other drugs like clozapine are generic. There were 4 clinical trials. Only 2 of them were published, so I have to assume that the other 2 were negative. And only one of the published trials showed consistent, statistically significant improvement over placebo. So I am not an enthusiast for pimavanserin. In the United States, the average retail price is $36,000 a year. To me, this is drug profiteering. If it worked as a miracle drug, I would embrace it. I've only given it to one patient, and he developed a movement disorder from the pimavanserin on top of his, which fortunately went away when I stopped it. Quetiapine is safe, but there's not been proof of effectiveness. There was a tiny randomized controlled trial that was positive. 2 that were a little bigger but still pretty small were negative, but it did not aggravate the Parkinson's. Other antipsychotics studied were either ineffective and or they worsened the Parkinson's. For theoretical reasons, it was thought the cholinesterase inhibitors might be effective. My neurology colleagues here who are specialists in Parkinson's believe in cholinesterase inhibitors, and they prescribe them for psychosis, but there's not an evidence base for it. Quetiapine is the most frequently prescribed drug. Clozapine is very rarely prescribed in Parkinson's, and it's clearly being underused. Neurologists are scared of it because of the agranulocytosis risk, and they don't want to deal with the hassle of signing up for the registry. Psychiatrists, sadly, in a lot of settings are still prescribing high-potency antipsychotics like risperidone. That's certainly the wrong thing to do. So here's my bottom line. While clozapine and pimavanserin are the only ones with some randomized controlled trial evidence, so it's much better for clozapine, it's reasonable to try quetiapine first because it's a lot easier to use. And if the patient responds, great. If they don't, then I would recommend clozapine. And note that low dose range. Don't prescribe high potency D2 blockers. Make sure their primary care physician isn't giving them Compazine or Reglan, which will be making their Parkinson's worse, and don't abruptly stop dopamine agonists. Seizure risk. How much risk do our drugs pose in a patient with epilepsy or even without epilepsy? Are they contraindicated in epilepsy? So the risk of seizure is about 1 in 1,000 to 5 in 1,000 for most antidepressants and antipsychotics. If a patient is receiving anticonvulsants for their seizure disorder, they can be given our drugs safely. I assume that most of you have been taught that bupropion significantly increases the risk of seizures. That's not really true. And here's where it came from. Again, most of you are way too young to know any of this. When bupropion was first clinically introduced, at least in the United States, the dose range was up to 750 milligrams. And then there was a study in women with bulimia who were actively abusing diuretics, laxatives, and purging, making themselves throw up, and 4% of them had a seizure. But they also had electrolyte disturbances. So the drug was taken off the market. The manufacturer restudied it and found that below 450, the risk of seizures with bupropion is no different than other antidepressants. At 450, it might be slightly higher. It might be a 0.4% risk. So that's still less than, less than 1 in 100. Of all of our drugs, the drug with the highest risk is clozapine, where the risk is 1 to 2% in just, all recipients of clozapine. It's also probably higher in low potency typical antipsychotics like chlorpromazine or thioridazine than it is with most of our other drugs. What my epileptologist colleagues tell me is that even in a patient with treatment-resistant seizures, where they might have the patient on 3 or 4 different anticonvulsants, they do not want us to withhold psychotropic drugs. They say, to whatever extent our drugs are lowering the seizure threshold, it's insignificant, and that untreated psychopathology is a much bigger problem from their standpoint because it breeds non-adherence with the anticonvulsants. So don't be afraid to use our drugs in patients with epilepsy. Tricyclics, our younger psychiatrists here, at least our residents, rarely use tricyclics. Tricyclics, I'm old school. Tricyclics definitely have their uses, but back before we had other options like SSRIs, tricyclics were found to be generally safe in most patients with stable heart disease. They were a risk in patients who were at high risk for heart block, like a patient with a new left bundle branch block. They were contraindicated after MI, however, as are most type 1A antiarrhythmics. SSRIs were shown to be safe for sertraline and SAD heart, the SAD heart study, citalopram and the Canadian CREATE study. There's no reason to think that safety wouldn't apply to other SSRIs. Uncommonly, they can cause bradycardia. I've only seen it a couple of times in my practice. I'm going to talk about citalopram and how much to worry about QT prolongation in a couple more slides. Mirtazapine was shown safe in unstable coronary disease or immediate post-MI in the MIND-IT study. Stimulants are safer than you gather from reading at least the US FDA black box warning. 2 large Medicaid studies, retrospective studies, showed no increased risk of cardiovascular complications in children, adolescents, or adults who were given stimulants, presumably for attention deficit disorder. I do use stimulants in elderly patients with heart disease. I do communicate with their cardiologist before doing so, and I start at very low dose. Esketamine is on the rise in the United States. It's being used somewhat irresponsibly in my own city. In the community, there are 2 freestanding esketamine or ketamine clinics. Actually, they're intravenous ketamine clinics. They don't have psychiatrists working there. They're run by emergency room physicians, and they're promoting ketamine and esketamine for all psychiatric disorders. In the registration trial for esketamine, 8% of the patients experienced a systolic blood pressure rise of over 40 millimeters of mercury. So imagine you have a patient with coronary artery disease who's just functioning at the very edge of their ability to maintain an adequate coronary perfusion. If we abruptly increase systolic blood pressure by more than 40 millimeters of mercury, they're at acute risk of a coronary event. And so S-ketamine and ketamine both are contraindicated in patients at risk for unstable heart disease. So how much risk do antipsychotics pose for prolonged QTc and torsade? And what about citalopram? So first, a word or two about the interpretation of the QT interval, because we're psychiatrists, we're not cardiologists. You need to know that when you look at the EKG printout, the computer is calculating a QTc. It's not actually measuring something in any physiologic way. And at high heart rates, the actual QTc is shorter than the one that the computer tells you it was. So the patients to really worry about are the bradycardic patients, because the true QTc is actually longer than what the machine tells us. There's some other formulas for calculating it that are more accurate in tachycardic or bradycardic patients. I don't remember them, but I don't look them up. I just ask a cardiologist if the patient's bradycardic or tachycardic, you know, to recalculate it. It's also misleading in patients who have bundle branch blocks. So all of our antipsychotics prolong the QTc to some degree. That may be why antipsychotics are associated with a risk of sudden death. It's fortunately pretty rare in medically healthy people. They're associated with that risk. That may be true in children as well. That absolute risk is small, but certainly we'd be uncomfortable with causing anyone to die from an antipsychotic. The risk of torsades is negligible if the QTc is below 500. But most patients above 500 are not going to get torsade. Patients who are on high doses of IV haloperidol should be on a cardiac monitor, and most patients who are getting IV haloperidol, after all, are in ICUs. Contrary to what my residents say, I have trouble getting them to stop writing this in notes. If we're recommending oral antipsychotics at moderate doses to treat delirium, they do not need an EKG every day, even when the dose is increased. High doses intravenously, it's not a bad idea to check. Low doses intravenously, not a risk. So the real risk is when a patient has a very high dose of an antipsychotic and other risks for prolonged QTc. And these are other risk factors for QTc. Some of them, like anorexia nervosa, are in our realm, or heavy alcohol use. Others are things that are likely to have been measured in the hospital, like electrolyte disturbance. I'm not going to dwell on this slide in the interest of time. I want to remind you that the drugs with greatest risk are first-generation antipsychotics and ziprasidone, and the drugs with lowest risk are aripiprazole and olanzapine. What about citalopram? It's not just my personal opinion, but cardiologists who are knowledgeable about this as well, that the US Food and Drug Administration grossly overreacted when they said no one should get more than 40 milligrams of citalopram and no one should get more than 20 milligrams over age 65. That risk of QT prolongation is very, very small, and cases of torsade are extremely rare with citalopram. And the risk has been when other risk factors are present, not just from prescribing citalopram. So if the patient is doing well on a higher dose and their QTc is below 500, leave it alone. I have a patient who's 80 years old and she's on 80 milligrams a day of citalopram because that's what it took to get her into remission, and she's done fine, and her QTc didn't increase. I very much recommend this document for you, for any of you whose practice this issue comes up. This was a document prepared by the American Psychiatric Association, the American College of Cardiology, but it was mostly a group of psychiatrists, and I was one of them. And it's on the American Psychiatric Association website under resource documents. You don't need to be a member to see it, to download it. And these were the overall conclusions, but there's a lot more information there. There is no number, there's no absolute QTc at which a psychotropic should automatically not be used. Instead, we should be engaging in a risk-benefit analysis of what's the pharmacologic risk and what's the non-pharmacologic risk. The risk for torsade versus the risk to fail to control high-risk psychopathology. How safe are sedative hypnotics in pulmonary disease? Benzos are very often prescribed in COPD, shockingly. In fact, even severe COPD patients are often given benzos, which is a questionable practice. I have found over 100 randomized controlled trials for the treatment of anxiety and asthma or COPD, and none of them are of psychiatric drugs. They're all of psychotherapy, behavioral interventions, relaxation, aromatherapy, etc. The reports are not randomized controlled trials, and they're mixed. In severe COPD, prescribing a benzo was associated with a 20% increase in mortality, and that's clinically significant since severe COPD patients have a lot of mortality. A large Veterans Administration study found that there was a small increase in mortality, but it was only in short-term benzo use. I don't know how to interpret that. In terms of hypnotics, there have been a very small number of randomized controlled trials. What they show is that in mild COPD, at low doses, benzos and Z hypnotics like zolpidem don't seem to affect respiratory function. They're safe. There's no data on trazodone or mirtazapine, but they're probably safe in mild COPD. The other things like melatonin, the other sleep medicines that are not sedatives, we wouldn't expect any effect on respiration, and indeed they don't have effects on respiration. So here's my bottom line. I don't think you should give benzos to patients whose COPD is to the point where they retain CO2. Remember that CO2 retainers, the CO2 can be kind of like a narcotic itself. It makes them sleepy, they start dozing off, and what keeps them from dying and just dying of CO2 building up higher and higher is that eventually the hypoxia alarm in their brainstem kicks them awake. Well, we don't want to sedate that with a benzodiazepine. I would also avoid benzos in patients with severe sleep apnea who experience steep desaturations, who get very hypoxic during sleep, because that too is something you don't want to sedate. If a patient has severe COPD and they have generalized anxiety disorder, I would try buspirone or an SSRI instead of benzos. If they have panic attacks and they have severe COPD, I would give them an antipsychotic because you need something that's going to work right away if they're having a panic attack. If they're a palliative care dying patient who has a lot of dyspnea, opioids are by far the first-line choice for treating terminal dyspnea. There's no good evidence for or against benzos, so I would only use those in a terminally ill dying patient if they couldn't tolerate opioids or opioids weren't working. I was taught that in patients with significant renal disease, a rule of 2/3, to use 2/3 the dose. I don't know if any of you were taught that. There's no empirical basis for that rule at all. There are drugs for which you should use the normal dose. Even drugs like venlafaxine or paroxetine, where we think of them as hepatically metabolized, and they are, they have active metabolites, some of which are really renally excreted. Venlafaxine clearance can be reduced 50% in an end-stage renal disease patient, and paroxetine similarly can, elimination is significantly reduced in dialysis patients. Remember that lithium, gabapentin, and pregabalin are renally excreted. They are dialysable, as are valproate and topiramate. In hemodialysis, I recently had a colleague, a psychiatrist, ask me whether he could use lithium to treat a bipolar patient who's on chronic dialysis. A chronic dialysis patient is the ideal patient for lithium therapy because they never get lithium toxic. Their lithium level doesn't change. You give it as a single dose after dialysis, and then none of it is excreted. None of it's going anywhere until they have their next dialysis. And so you measure a level on the non-dialysis day. The same thing is true for gabapentin or pregabalin. For example, if they're getting that in a diabetic patient for diabetic neuropathy, if their renal function is declining, they're at risk of getting gabapentin toxic. In fact, we've seen some delirium consults where that was the cause of the delirium. But if they're all the way to dialysis, they should get the gabapentin or pregabalin just 3 times a week right after dialysis. How much risk does lithium pose to the kidney? In the interest of time, I'm going to skip to a couple of bottom line points. One is that patients with bipolar disorder, not all of the end-stage renal disease that has occurred in them can be assigned or blamed on lithium. In fact, there are studies that show that patients who've been on other mood stabilizers had as high a risk of eventually develop end-stage renal failure as the patients got lithium. And that's because other medicines like analgesics are overused in bipolar patients. They're more likely to engage in substance abuse. They have higher risk for hypertension and diabetes, sometimes caused by the drugs we're giving them. And so these other comorbidities are often the culprit. So here's my bottom line. While it's still somewhat controversial, lithium is so efficacious in bipolar disorder that the risk of renal dysfunction with chronic use is considered acceptable as long as you're checking their renal function at least once a year. You should aim for the lowest effective dose. Unfortunately, studies in a whole bunch of wealthy countries show that many prescribers are not checking lithium levels and creatinine levels as often as they ought to. So in the first year, it probably should at least be every 3 to 4 months. If you have a very reliable patient who doesn't have a medical condition that might cause renal decline, then eventually once a year can be okay. But you do need to check. But don't be afraid to use lithium. How should psychotropics be managed in the perioperative period? So there are risks of continuing our drugs in somebody who's facing an elective surgical procedure. If it's an emergency surgery, there's no time to think about whether to stop the drug. So some of our drugs could have adverse interactions with anesthetics. Some could interfere with managing the patient's blood pressure. And some can promote postoperative complications like making the patient too sedated or giving them a post-op ileus. But the risks of stopping our drugs just before surgery, taking away the therapeutic effect, can lead to rebound exacerbation of the mental disorder. You will not make the surgeon your friend if you cause the patient to have a manic episode or a profound depressive episode in the immediate perioperative period. And of course, some of our drugs, if abruptly stopped, cause withdrawal symptoms. So which risks are greater, the risks of stopping or the risks of continuing? There's very little evidence, and the likelihood of ever doing a randomized controlled trial, it's very unlikely. So here's my bottom line after talking with surgeons and anesthesiologists. The risks of stopping usually exceeds the risk of continuing. SSRIs might be an exception, as I mentioned earlier, in a patient who's at very high risk for perioperative bleeding, but not in most patients. The one exception, oddly enough, is the cholinesterase inhibitors. The drugs that I would have the least worry about stopping before surgery, and that's because they increase the effects of depolarizing blockers like succinylcholine, and they reduce the effects of non-depolarizing agents like atracurium. And while the anesthesiologist can make adjustment for that, either one of these, I think it's better to just stop them before elective surgery. What's the risk of osteoporosis? And which psychotropic drugs is this a concern with? It's with those that cause increases in prolactin. And mostly that's with D2 blockers, and it's proportion to how potent they are at the D2 receptor. So the highest risk is with butyrophenones like haloperidol, with phenothiazines, and the highest risk of all is with risperidone. The lowest risk is with aripiprazole and ziprasidone, but keep in mind that SSRIs, opioids, and phenothiazine antiemetics can all increase prolactin release as well. Prolonged or persistent hyperprolactinemia will induce hypogonadism. It lowers estrogen in women, it lowers testosterone in men, and among other things, those are associated with decreased bone mineral density and osteoporosis. So I would not worry about this when these drugs are used for months, but when we're giving an antipsychotic for years, we should be mindful of this issue. In fact, the second bullet on this slide, I think, is most significant. Patients have been on long-acting injectables. Half of them had significant increases in prolactin. And 92% of those who were on paliperidone, long-acting injection, had elevated prolactin levels. So there's no consensus, to my knowledge, about whether we should routinely screen before or after prescribing an antipsychotic. Clearly, you should check a prolactin in a symptomatic patient. And I mean a patient who's got symptoms not of the osteoporosis, but symptoms of hyperprolactinemia. So sexual dysfunction, menstrual disturbance, galactorrhea, gynecomastia in men. And there's no specific recommendations in literature for measuring bone mineral density. I think we should monitor our patients for sexual dysfunction, changes in their breasts and menses. If they're on a very high dose of a high potency agent, especially a long-acting injectable, they probably should have a prolactin level checked every year. And if the prolactin level is staying elevated all the time, and we can't switch them to a different antipsychotic, they probably should have their bone mineral density checked. I don't do that myself. I ask their primary care doctor to do that. There's at least theoretically calcium supplements and vitamin D, and certainly exercise. Getting a chronic psychotic patient exercise can be difficult. Using the lowest effective dose is always good at preventing adverse effects. Changing to a lower risk antipsychotic, if the patient's already at high risk for osteoporosis, probably would be a good idea. Some authors have suggested treating with a dopamine agonist, which might promote, which will reduce prolactin levels. But the drug usually used for that is bromocriptine, and because it's a dopamine agonist, it may exacerbate psychosis. So I wouldn't recommend that. There are medicines to increase bone mineral density. I don't think psychiatrists should be prescribing them, but you should know about their existence. And if you want to read about this more in detail, look at that last bullet, the reference there, which bring together endocrinologists, psychiatrists, and others. Drugs causing suicidality. The United States FDA became really overly vigilant and overly worried about this after the issue was raised with paroxetine, and unfortunately scared a lot of clinicians into not prescribing paroxetine in children and adolescents. And in fact, the rate of prescribing of SSRIs went way down in adolescents and children, and the risk of suicide went up when that happened. There clearly is a risk of suicidality with interferon alpha. Now that we have better drugs for hepatitis C, you're much less likely to see an interferon alpha patient, although it's still used to treat some cancers. Isotretinoin, that's Accutane, the acne drug. It's controversial whether it causes suicidality at all. If it does, it's extremely rare. The fact that the patient has a history of having made suicide attempts should not automatically disqualify them from getting the drug. You should be aware that in adolescents with acne have twice the suicidality of adolescents without acne. That's without any treatment at all. Acne is very depressogenic in teenagers. The US FDA warns about suicidality with anticonvulsants, but here again it's confounded because there's clearly a much better established risk that people with epilepsy have an increased risk of suicide. I do not think that there's an increased risk with anticonvulsants. What you'll find if you look at the literature is one study will find an increased risk with 2 of the anticonvulsants and not the others. And when you look at a bunch of studies, there's no uniformity. So one study will say that carbamazepine increases the risk, and the next 3 studies will say it doesn't. There's no anticonvulsant that across all those studies was shown to increase risk. Leukotriene modifying agents used for asthma, again, I don't think there's any objective evidence that it increases suicide risk. So I think the last topic I'm going to take you on, and thank you for hanging in there through our technical difficulties. And this mostly comes up in the inpatient setting, but occasionally for patients who, as an outpatient, either have no functional gastrointestinal tract or it's been put to rest for a period of time. How else can we give our drugs if we can't give them orally? So let me take you through each of the antidepressant classes. I'm assuming that there's no parenteral antidepressant available in Mexico. Citalopram is available in Europe, and clomipramine used to be available in Europe before SSRIs came along. I don't know of anybody in the United States doing this even off-label. Rectal suppositories, there have been some case reports. I had a couple patients many years ago who were inpatients who were on prolonged periods of nothing by mouth, where I could get our pharmacy to make up cocoa butter suppositories. They won't do it anymore. It's too much of a hassle. The only antidepressant, at least in the United States, available for transdermal use is selegiline. There are some buccal oral disintegrating tablets. And I was hopeful that maybe mirtazapine, when held in the mouth, that there would be some buccal absorption, but the one study that's been done shows that it's not absorbed that way. If the patient doesn't swallow it, it has to get to a viable gastrointestinal tract. So we really have no good route to give antidepressants to somebody who can't take something by mouth. Benzodiazepines are the opposite exception. Benzodiazepines will be absorbed through any mucous membrane. I'll bet if you put it against the eardrum, it would get absorbed, although I wouldn't recommend that. So they can be given IV, they can be given intramuscularly. In the US, diazepam is FDA approved for intramuscular injection, but I do not advise diazepam intramuscularly because the absorption is very erratic. So if you're going to give it IM, stick to lorazepam or midazolam. While there's no sublingual form in the United States that's been approved, any benzodiazepine that's in a tablet rather than capsule form, if it's held under the tongue or cheeked like chewing tobacco, it'll get absorbed. There are studies showing that it's absorbed nasally, intrathecally, rectally. Diazepam gel is commercially available. It's mostly used in children with status epilepticus. Other benzos, liquid form, can be administered rectally, and they will get absorbed. What about antipsychotics? Of course, haloperidol is available IV. Olanzapine and ziprasidone have both been given intravenously. Don't forget intravenous chlorpromazine. I find it very useful for extremely agitated, violent patients in the ICU, where you really need to knock them off their feet to keep them from hurting anybody. And if it makes them gives them some postural hypotension, well, it makes them less a risk. We have lots of options, both first and second generation antipsychotics for intramuscular injection. Acenapine is available for sublingual use. There's not really good evidence that olanzapine, the oral dissolving form, will get absorbed buccally or sublingually. It's not been well studied. Subcutaneous antipsychotics, that's mostly been used, they've mostly been administered in palliative care settings where somebody is dying. There's no IV because they're trying to avoid an IV. You can, and the patient also might not have good veins anymore if they're too cachectic. Haloperidol or flufenazine can both be given subcutaneously. And then acenapine is also now available for transdermal use. Mood stabilizers, valproate or carbamazepine can be given IV. Lithium has been studied IV, but it's not commercially available. Several of the anticonvulsants are available for rectal use, and that's, of course, because of status epilepticus, but there's no reason we couldn't use them that way. Let's say in a bipolar patient who, for GI reasons, was told they couldn't swallow anything for months. Methylphenidate is available in transdermal form, and rivastigmine is available in a transdermal form. And the sign of my dog is the sign that we've reached my last slide. I would have much preferred to have been there in person and had dinner with you all, but we'll have to wait till some future date when COVID is not distorting our societies. I have time for a question or two if people do have them. I have to get off at 11:30 because we're doing a Zoom graduation for all our trainees today.
Thank you very much, Dr. Levenson, for this wonderful talk. We have a few questions, just 2 or 3 if you can. A colleague of mine told us that how often do you recommend to do this EKG in patients who have these depot antipsychotics?
So there's nothing written in stone. So if it's a patient on a depot antipsychotic and they have no risk factors for heart disease and no particular risk factor for QTC prolongation on Torsade, so there's no family history of unexplained sudden death. They don't have a reason to be repeatedly calcium or magnesium deficient. I don't think you need to do an EKG at all.
Okay.
But let's say it's a patient who's an older patient with schizophrenia, and he's had serious heart disease, and he's prescribed amiodarone, which itself prolongs the QTC interval, and he's on hydrochlorothiazide for his hypertension, which may deplete his potassium. I think he's going to need EKG relatively often, but I'm not going to be the one ordering, and I'm going to say to his cardiologist, be aware my drug may be adding to the risk.
Okay.
Please keep an eye on it. Let the cardiologist do that because he or she is the expert.
Okay. Okay. The second one is, do you recommend any SSRI for a patient who has coagulopathies, and if you recommend any kind of antidepressant?
I'm sorry, who has an SSRI for which problem?
Coagulopathies. For example, a patient who have hemophilia.
Well, yeah, I think there's no reason to think that SSRIs would aggravate bleeding in somebody with hemophilia, but I probably on general principles would start with something like bupropion or mirtazapine first and avoid a serotonergic antidepressant. You know, I thought for the longest time, somebody should do, here's a very simple study that nobody has ever done. In a group of healthy patients who are going to be starting on an SSRI, do a bleeding time before the SSRI started, and then a bleeding time after they've been on the SSRI for long enough for it to have been at a therapeutic level. And then that might be a way to tell whether we're really significantly increasing risk in a more high-risk patient would be to measure it before and after. But I've never done that myself, and I've never seen it done.
Okay. Well, thank you very much again, Dr. Levenson. We have a lot of questions, but you have this this next meeting. We hope you, Dr. Levenson, that maybe in the future, after the pandemic ends, we will hope you see here in Mexico, and maybe a couple of us going to the CL Psychiatrist Congress. Thank you very much again. Gracias a todos por estar acá. Thank you again, doctor, and see you soon.
I look forward to seeing some of you at the Academy meeting, although I expect it may be virtual this year. Yeah. And let's all pray for a return to normality, politically as well as health-wise.
Okay.
Bye-bye.
Thank you. Thank you very much. Bye. Gracias a todos. Que tengan buen día.
Gracias, gracias. Bye.
Bye, Lizeth. Cuídense.
Gracias, Carlos.
Bye, bye. Vamos a grabar la sesión y la mandamos a Argenis.
Sí.
Listo, Argenis. Ya grabé el chat y pues voy a terminar la sesión para que se grabe. Te voy a mandar luego los dos links para ver si tú lo puedes juntar y hacer de lo que se graba en la plataforma, en la carpeta Zoom. Te mando los dos links, el MP4 y el BM, no sé qué link, y creo que ya tú los puedes juntar, ¿no? Para hacer uno solo. No te escucho, perdón.
Mándame toda la carpeta.
Te mando toda la carpeta, perfecto.
Sí.
Muy bien, muy bien. Muy bien, Jenny, gracias. Te dedican algunos. Te cachaste muy rápido a los piratas, qué bueno. Pero bueno, ya voy a terminarla. Gracias, Argenis, y nos vemos, pues, bueno, por ahí nos contactamos a ratito para la...